Good evening and welcome to another Igenomix webinar. Today we are talking about the use of next generation sequencing in newborn screening. And to discuss this interesting topic, we have as a panelist Dr. Chandra Kumar and Dr. Ayman El-Khattab. Dr. Chandra Kumar is Senior Consultant and Head of the Department of Neonatology in the Hospital for Children in Chennai. And Dr. Ayman El-Khattab is Professor at the College of Medicine and Consultant of Clinical Genetics at Mediclinic City Hospital in Dubai, and Scientific Advisory Board member for Igenomix. We will be able to send, you will be able to send the questions using the chat, and we will have about 10 minutes of discussion after the talks. Sorry again, we have some problems, technical problems. Dr. Khattab, could you turn on your camera, please? Okay, I think that we can start with you, if you don't mind. We'll change the order, okay?
Okay.
Thank you.
Yes. So good evening, everyone. I'm really glad to talk about newborn screening and the use of next generation sequencing. I will start with a brief introduction about newborn screening. It's a public health program, and the goal here is to screen newborns for conditions that can be treated, but at the same time, these conditions are not evident, not clinically evident in early life. So we need to look for these conditions and identify them early in life to be able to start treatment early on and prevent morbidity and mortality. And these screening programs should cover all newborns and should be done early in life. It's important also to distinguish between screening and diagnostic procedures. So when we say screening, it's something applicable to apparently healthy individuals. And if we have a positive screening test, it doesn't mean that the child or the baby has this condition. It only means that we need to do confirmatory tests. While diagnostic tests are done if we have positive screening test or if we have symptomatic patients and we are concerned about a specific condition, then we do a diagnostic test. So little about the history. The story started in the 1960s when Robert Guthrie described the initial screening for phenylketonuria using the bacterial inhibition assay to assess the level of phenylalanine in the filter paper from newborns. Then in 70s, people start adding more diseases, start adding like here congenital hypothyroidism. Then the bacterial inhibition assay use was expanded to include the maple syrup urine disease and classic galactosemia. Then the breakthrough came in 1990s when people started using mass spectrometry to look at different amino acids and acid carnitines. And during that time, now we start being able to screen for large number of conditions and using one method and one small sample. So nowadays we have many conditions and many methodologies to do newborn screening. Of course, like for example, like hearing test. Here we do hearing test as part of newborn screening in many countries, and also many places added for congenital heart defects using pulse oximetry. Severe combined immune deficiency using certain PCR techniques to look at the tricks or the T cell receptor exogen circles, cystic fibrosis, some endocrine disorders like congenital adrenal hyperplasia and congenital hypothyroidism, and long list of inborn errors of metabolism that can be detected by mass spectrometry, including amino acidopathies and urea cycle disorders. And by looking at different acylcarnitines, we can also screen for large number of organic acidemias and fatty acid oxidation disorders. So the method for mass spectrometry, briefly, we take 5 or 4 circles and dry blood in a filter paper, and this is done typically second day of life, and we leave them to dry, and then we run them through the mass spectrometry where we separate a very large number of molecules, including amino acids and acylcarnitines, and we can screen for a large number of amino acidopathies, organic acidemias, and fatty acid oxidation defects. However, we still have like many conditions that are not included in many newborn screening programs, and these, like here we have like some examples of conditions, storage diseases that we have enzyme replacement therapy for, like Pompe, Hurler, Fabry, Gaucher. All these conditions are can be treated, and early diagnosis for these conditions is very important. This is why people kept adding more and more conditions to newborn screening, kept adding more methods, and now we will be looking at the utility of next generation sequencing. So because we continue, there is continuous growth in the conditions that we add in different newborn screening programs. The methods are, again, sometimes you add in new methods to in newborn screening. Now, the people started thinking about using next generation sequencing, or NGS, and it will be the next big expansion. Because you can test for large number of diseases, and all this can be done in one method. So you can really expand the conditions that you test for, at the same time unify the methods. However, we still have many challenges and limitations in using next generation sequencing in newborn screening, and most of these limitations are summarized in this nice diagram. So we can divide them into technical issues, economic considerations, medical, and finally legal and ethical. So for the technical consideration, the main thing is the turnaround time. I mean, we know the goal of newborn screening is to diagnose babies before they become symptomatic, to start treatment early and minimize the complications. So this is why the turnaround time is important. We need to be able to get the results in a timely manner, so we can start treatment before the baby becomes symptomatic. Then how accurate our results are, and this all depends on the methods and the methods of detection, detecting the variants. Are we going also to be able to detect copy number variations? And there are many other technical issues that can affect the accuracy and exactness of the results. Then, of course, if we say this is a screening, then indeed we will need confirmatory tests. So we need to have to confirm the results of the newborn screening. And of course, the interpretation of results is another issue that depends both on software programs, and it depends also on human expert interpretation. And when we have these sequencing, we have a huge amount of data that need to be stored and need to be stored safely. Regarding the economic consideration, of course, the cost. The cost is one big challenge, although like with the advancement in technology, the cost of NGS is getting lower and lower, making this challenge less. And of course, but we will also the cost of sequencing, but also we have the cost of data analysis and storing data and adding experts to look at these results, the cost of confirming the results of the newborn screening also. Then we have the medical considerations. I mean, what to test? Like in NGS, we can do few genes, we can do many genes, we can do whole exome, we can do whole genome. So what to choose? And if you decide, and the other thing is like if you decide to do a gene panel, which genes should we include? And we will talk about this in the coming slide. And then how to interpret results. So we need database for normal changes and database for pathogenic changes. So to help us in interpreting the variants that you will get. And of course, the reporting is another aspect that that we need to think very carefully about. Like, for example, should we report variant of uncertain significance? What about diseases of late onset that will not appear during childhood, so forth. So there will be like should have like clear guidelines for what to report and what not to report. And then of course the legal, ethical, and psychological limitations. Like, should we have like a consent for these tests? Can people opt out of doing the test? And what can, like, again, if we're testing the infant, we can find things that can have implications for the family. And sometimes we are uncertain about the diagnosis, or the diagnosis is inconclusive, and how to present that and prevent overdiagnosis, and at the same time prevent overprotective parenting. So all these aspects need to be considered carefully. I'll talk about one aspect in little more detail, which is gene selection. Which genes should we include? And this nice diagram includes like the 4 different NGS newborn screening. And if you notice here, yes, maybe we have 74 genes that are common among all of them, but still we have a large number of genes that are done by only 1 or 2 labs. So clearly we don't have a consensus between all these labs what exactly to include in the gene panels. However, we have like criteria that we can that can help us in deciding which genes to include and which genes not to include. And this criteria depends on the severity of the disease. So of course, the more severe the disease, then for severe diseases, then yes, we think okay, should be prioritized early onset diseases versus late onset, of course, and penetrance of the gene and likelihood of developing the disease. So you don't want to include low penetrant diseases that someone may have the mutation and live all his or her life without having any complications. Of course, knowledge of the disease is important, and what do we know about genotype, phenotype? This will help us in deciding on which conditions to include. And finally, and very, very importantly, the treatability of the disease, or at least the actionability on the disease. I mean, if we make a diagnosis, how can we help the affected individual? So these different points, they can place together to making like a scoring system. If you put all them, and then you can score them. So for example, like these that score high, you can say, okay, these are category 1, and we need to include them. Then if less for Category 2, less priority, and then we have this in between that open to discussion. So by putting all these together, we can have like kind of a guidance of which conditions should we include and which conditions we may delay for like later stages. I will talk little about what we do in Igenomix. We have a panel of 237 genes, and we focus on severity and the early onset, and of course the treatable or actionable diseases. Most of these diseases, as expected, are inborn errors of metabolism, but also we include endocrine disorders, immunodeficiency disorders, deafness, and others. And in these others, we have some hematological disorders, of course, spinal muscular atrophy, and others. Besides NGS methodology, we do some additional methods for particular genes, like for Duchenne muscular dystrophy and spinal muscular atrophy and congenital adrenal hyperplasia. We do additional methods to improve the detection rate and make the process more accurate. Now, if we look at the current conventional newborn screening in different parts of the world, the incidence of diseases detected by these diseases range between 1 and 3 per 1,000. But if we look at the diseases, more than 200 conditions in Igenomix NGS, the incidence for these conditions will be around 7 in 1,000, which is like definitely we will be detecting a much more conditions than conventional newborn screening programs. If we have positive results, then again, the positive results will require confirmation. And of course, these patients will be referred to medical doctors who will do the necessary action. Some of them will need intervention and treatment. And of course, we'll be able to provide them with genetic counseling. And it's always recommended to do carrier genetic testing for parents. Now, of course, I mean, identifying recessive condition in the child has important implications for future, because now we can prevent the recurrence of this condition in future pregnancies using in vitro fertilization and pre-implantation genetic testing. Now also, if we identify carriers, this will have also implication mainly on reproductive implications because if the baby is carrier for a condition, then we will go back and test parents to determine the carrier genetic, the carrier status, and we'll provide the necessary genetic counseling. And negative results, just we can also only provide counseling if required. Yes, I think ideally, yes, we need to report pathogenic and likely pathogenic. For variant of uncertain significance, we don't have enough information to say this will have significance. So the important part is the pathogenic and likely pathogenic, where we have enough evidence that this mutation or this variant is linked to the disease, and this will be reported. Now, if we say like whom should be tested, I mean all healthy babies. It's a screening program, so ideally all babies should be tested, and babies healthy individuals. Now, if we have a sick baby, if we suspect a specific condition, screening test is not ideal. We need to do diagnostic, and of course, if we have positive results, this needs to be confirmed. When to do the test, the sooner the better. I mean, again, the whole idea of a screening program is early diagnosis. So yes, we can do it during the first 2 months of life, but of course the sooner the better. These are genetic tests, so they can be done anytime. Our genes won't change. It's different than the biochemical test. But of course, the earlier, the better. And what samples we can do now in the conventional test, the dry blood spots, we have to have blood samples. But in genetic NGS testing, we can think about like using other samples, and the easiest thing is buccal swab. This is non-invasive, easy to collect, and of course, like this will avoid. Sometimes parents don't want to prefer not to stick the child. So this will make it much easier. Now, the other thing, at this point, we collect samples from healthcare providers, but in the future, we can provide directly to patients. Oh, sorry. Now, regarding the workflow, so first, it's important to do a pre-test counseling to inform parents about the test, the expected outcome, and this is really pre-test counseling is important. Then we provide the kids should be already in the with the doctors, and the samples can be collected and then shipped to Igenomix. The test is performed and the report is generated, and then we have a post test counseling to explain results and implications. Now the turnaround time is about 30 calendar days, but with time this turnaround time will be reduced. We always provide virtual meetings with counselors and specialists to explain more about the utility of these tests. Finally, this is my last slide about why Igenomix decided to add this test. If you look here at this figure, here we do in Igenomix diagnostic, mainly in children, but also for adults and neonates. And we do carrier testing and pre-implantation genetic testing. Also, we do prenatal testing and screening. And also we do like for stillbirth. So the newborn screening was here to complete all aspects of genetic testing, and it's always there are opportunities to increase the screening and adding more conditions, and really the best way to do that is start now thinking about the NGS. So this was my last slide, and thank you very much.
Thank you, Dr. El-Khattab. So let's move on. We can start with the next talk. Dr. Kumar, if you want to turn on your camera.
Am I audible?
We can see your slide, but we don't see you.
Is it okay now?
Yes. Right.
Fine. So sorry for the technical glitch. So thank you for this opportunity. So in the next 20 minutes, I would be discussing about the Indian experience with newborn screening, the disadvantages of the available screening methods, and how we should go about in what is the future of newborn screening in this part of the country. So when you look at this, you can clearly see here in this lecture that I'll be discussing about the definition of newborn screening, criteria, what are the methods available, the Indian experience, what are the recommendations from Indian bodies, and if there are any drawbacks of the available system methods, so that we can go to the next generation of tests which are available. I'm sorry, I'm facing some technical issues. I'm not able to change my slides. Yeah, fine. So newborn screening is a public health program of screening in infants shortly after birth for some conditions that are treatable but not clinically evident in the newborn period. So the goal here is to identify infants at risk for these conditions early enough so that we can confirm the diagnosis and provide intervention that will prevent or ameliorate the natural progression of the disease. Public health programs should cover 100% of the newborn population, and it should be performed within 1 month after birth. So that is the importance of newborn screening. You are trying to identify something which is not presenting clinically early in the newborn period. So when you look into the history of newborn screening, it started early in 1960s. Robert Guthrie, a pioneer of screening for phenylketonuria, he developed a test based on bacterial inhibition assay to measure phenylalanine levels in blood samples obtained by pricking a newborn baby's heel on the second day of life on a filter paper. So he is from US, and he was the pioneer who developed the first test. Then later in 1970s, congenital hypothyroidism also was one of the disease which was widely screened. Guthrie and colleagues also developed other bacterial inhibition assays for detection of maple syrup urine disease and classic galactosemia. In 1990s, a new invention of what is called as mass spectrometry revolutionized the newborn screening program and led to a large expansion of potentially detectable congenital metabolic diseases, which included amino acid and acylcarnitine abnormalities. So Guthrie's bacterial inhibition assay has been slowly replaced by mass spectrometry, but however, the filter paper in which he collected the blood samples is used still worldwide. So when you look at the components of newborn screening, it does not start with only collecting the sample and doing the test. Before that, you need to educate the parents about the importance of screening. The parents and the public, you need to make them understand the importance of screening. Then the actual procedure of screening, wherein you collect the sample by doing a heel prick in the baby and collect the sample on filter paper, and then you run appropriate diagnostic method to identify the abnormalities, and then you follow up the results with the patient. You inform them of any normal, if it is normal or abnormal. Then if abnormal results are there, it has to be confirmed by appropriate diagnostic test, and appropriate management should be provided for the condition. And overall, the newborn screening program as a whole should be monitored and evaluated so that you can provide appropriate feedback and improve the implementation of program in a large scale. So before introducing any screening program, there are some certain principles which were laid back by Wilson and Jugner early in 1960s. So what they said was the condition should be an important health problem. So you should not do it for something which is very rare. There should be an accepted treatment for patients with recognized disease. Facilities for diagnosis and treatment should be available. There should be a recognizable latent or early symptomatic stage for that particular disease. So there should be a suitable test which identifies this condition, and the test should be acceptable to the population. The natural history of the condition, including development from latent to declared disease, should be adequately understood. There should be an agreed policy on whom to treat as patients. The cost of case finding, including diagnosis and treatment, should be economically balanced in relation to possible expenditure on medical care as a whole. So case finding should be a continuous process, and it should not be once and for all project. So you should be, once initiated, this program should be sustainable. So that is where the problem most of the public health programs in developing countries may face. So when you look at the techniques which are involved, the technologies in newborn screening, as I told you, it started with bacterial inhibition assays and single biochemical assays earlier. Then other methods subsequently replaced the older techniques. The one which is commonly used nowadays is called as tandem mass spectrometry, or otherwise called as TMS or MSMS. So there are other conditions. There are conditions which are identified in the newborn screening program, which is not through these biochemical tests, but by other methods. So, for example, hearing loss in infants is identified by using mass universal newborn screening for hearing, which includes measurement of otoacoustic emissions, or otherwise called as AABR, where automated auditory brainstem response is measured. Congenital heart defects can be identified by using pulse oximetry. Severe immunodeficiency, combined immunodeficiency, otherwise called as KID, is identified by using T cell receptor excision circles or TRUCs, which is a PCR-based technique. Cystic fibrosis is identified by high levels of immunoreactive trypsinogen, identified by ELISA. Congenital hypothyroidism, where elevated thyroid stimulating hormone is identified again by ELISA. Congenital adrenal hyperplasia, where elevated 17-hydroxyprogesterone levels are identified either by mass spectrometry or radioimmunoassays. And then inborn error of metabolism, where abnormal amino acid profile or acyl carnitine profile or phenylketonuria, it is identified by using tandem mass spectrometry. So once identified, these disorders, most of these disorders have some form of treatment which is available. So primary congenital hypothyroidism, which is identified by elevated TSH and a low T4. So the incidence can be as high as 1 in 2000. In some countries, like it can be even higher. So you have suitable replacement therapy called thyroid hormone. So once initiated, the symptoms like intellectual disability, developmental disability, other brain damage will be totally ameliorated. Similarly, the other condition called congenital adrenal hyperplasia, which is identified by elevated 17-OHP levels, which is the incidence could be 1 in 10,000 to 12,000. A suitable treatment with glucocorticoid and mineralocorticoid therapy is available for such condition. So what is the status of newborn screening in India? So India is a vast country. It is a subcontinent with more than 1 billion people. So there has been a wide variation of incidence of these conditions have been reported in the literature. Here you can see that incidence of congenital hypothyroidism was as high as 1 in 8 in one of the study which was done in early 1980s. But now the present time studies quote about the incidence to be around 1 in 800 to 1 in 1000. Okay, so it is much more common. Congenital hypothyroidism is much more common than what is reported in other parts of the world. You can see that aminoaciduria occurs in 1 in 1000 population. The other study quoted the incidence of congenital hypothyroidism to be somewhere between 1 in 1700 to 1 in 3000. So the other common condition which has been screened in newborn screening programs, which is done in India, includes the incidence of glucose 6-phosphate dehydrogenase deficiency. So it has been reported to be around 0.38% in males and 0.07% in females. So newborn screening in India is being kind of conducted in private institutions. So this is one of the largest data which is available, wherein I was also part of the study. So in this retrospective study, we analyzed almost 48,600 results, in which we found that 4.1% of the results were abnormal. So abnormal acyl carnitine profile was found in 2 per 1,000. Abnormal amino acid profile was found in 7 per 1,000. Abnormal TSH was found in 1 in 1,000, and abnormal 17-OHP was found in almost 1 in 3,000. Cystic fibrosis, that is elevated IRT, in 1 in 6,000. By looking at the data, it is very much obvious that incidence of these conditions may be quite much more common in Indian subcontinent than rest of the world. So India is a vast country with wide variations in infant mortality rate. When you look at the recommendation of World Health Organization on when to initiate a screening program, newborn screening program, WHO says that it should be initiated when your infant mortality rate is less than 50. So you can see here that some of the states infant mortality rate is as low as 10, and it is as high as 47 in some of the states. But still, overall, the Indian infant mortality rate has reached below 50, and probably this is the right time for us to start any newborn screening program. So incidence of hypothyroidism is really high in India, and probably incidence of IEMs also may be high based on the studies which I have quoted. And it may be due to the high incidence of consanguineous marriage in South India and in some religious communities. So to identify incidence of these common disorders, in 2007 to 2012, Indian Council of Medical Research conducted newborn screening tests based on these 5 cities: Delhi, Mumbai, Calcutta, Hyderabad, and Chennai. So in this, what they found was that incidence of congenital hypothyroidism was 1 in 1500 in the northern city of Mumbai. Congenital adrenal hyperplasia was 1 in 9,983. That is 1 in close to 10,000. But in the southern city of Chennai, they found that congenital hypothyroidism was as high as 1 in 727, and congenital adrenal hyperplasia was much more common. That is 5 times more common than what it was in Mumbai. It was 1 in 2036. So there is a wide variation in the incidence of these diseases, which can be potentially identified through effective newborn screening programs and can be treated. But still, NBS is not yet public funded. One state, the state of Goa, ran a public funded program between 2008 and 2013, but it has been discontinued later due to the findings which was reported that these conditions are very rare and the funds were diverted for other purposes. But having reached an infant mortality rate of less than 50, we are at the right time to initiate this program. And now, for the past 1 decade probably, that is being run in more and more private institutions in India. But yes, it involves out-of-pocket expenditure from the parents. So newborn screening by biochemical methods has its own pitfalls. It cannot detect some of the disorders like NKH, intermittent MSUD, respiratory chain defects, tyrosinemia type 1. And some of the diseases for which effective treatment is available may also be not detected by newborn screening program. Example includes Pompe's disease, where abnormal alpha glucosidase activity is identified, which occurs in 1 in 28,000 population, and an appropriate enzyme replacement therapy is available. Hurler's disease, again, bone marrow transplant and enzyme replacement therapy is available. Fabry's disease, which can be, the incidence can be as high as 1 in 1,500. Here also enzyme replacement therapy is available. Gaucher disease, where enzyme replacement therapy is available. So all these conditions may not be identified by the existing newborn screening program, so that we need to resort to better screening tool which can identify these conditions. So NBS is one of the essential screening program, and I think it is right time for us to start screening for these diseases in India, because incidence of congenital hypothyroidism and adrenal hyperplasia at least is higher in India. Other IEMs also may be higher when compared to the other population. So experts in India feel that it is right time to introduce screening, and advantages of biochemical methods or disadvantages over other methods has to be individualized, and institutional policy should be derived before choosing an appropriate test for the population. Thank you.
Thank you, Dr. Kumar, for your talk. So, Dr. El-Khattab, could you turn on your camera? Okay, so let's start the discussion. So we have around 10 minutes only. It has to be very, very short, sorry. So let's start with Dr. Kumar. So in your experience, you have extensive experience with newborn screening in India. So do you think that there are other group of diseases or genetic disorders that are not included in the existing newborn screening, and because of the consanguinity, the prevalence is high enough to include or not?
Yes, yes, there are definitely. I mean, there are other diseases which can potentially be identified, as I told. Gaucher, Pompe, we do see a lot of these cases, and of course, these cannot be identified by the existing newborn screening panels which are available in India. And we need to use the next generation testing, probably this mass sequencing kind of testing, which can identify these conditions so that these infants can be picked up early and appropriate intervention can be provided.
Okay, thank you. Dr. El Khattab, we have another question here from the public, and the question is, which genetic tool you would use for the newborn screening, genetic newborn screening? The panel of genes, the exome, the genome?
So I think at this point, the panels are what we have been, what many people started using, and however, with more experience, because we just started with this utility, with the utility of NGS and newborn screening. So I think we need to learn from our experience. So gene panel at this stage is I think the most appropriate, but in the future, yes, most likely the panels will expand, and at one point, yes, people will consider exome and genome, but to start with, yes, gene panels.
Okay, thank you. So to both of you, do you have any experience in India or in Emirates, Arabic Emirates, about genetic newborn screening, or there is any plan to implement this system, this genetic newborn screening? Let's start with India, for example.
Yeah. If I may answer this question, so far, to my knowledge, I mean, we have not resorted to this genetic-based screening in India. To my knowledge, I may be wrong also, but I think there is a potential a space for introducing this screening methods, so that certain diseases definitely for which replacement therapy options are available, interventions are available, can be picked up early, and these children and families can be helped. So definitely there is space for introducing this genetic based screening in India.
Thank you. Dr. El Khattab?
Yes, so no, at this point, we don't have any, we have the conventional newborn screening. However, yes, we like it. I think in the near future, this will be considered. They started big genome project in this country, and they're also thinking about using NGS for premarital genetic screening. And at one point, yes, the newborn screening will be like using NGS for newborn screening will be considered in the near future.
Okay, thank you. We have another question to both of you, if you want, about some diseases that there are not a good correlation between the genotype and the phenotype. For example, with Fabry disease, that in some cases we will not able to know when they will develop or not the disease, on the severity of the disease. What happened with these diseases? For example, with Fabry disease, you would include Fabry disease in the genetic newborn screening?
So
sorry, please go ahead.
Yeah, that's one. Yeah. So I mean, again, it will be a list that will prioritize the genes the gene that are selected to be included in the NGS panel. So this is one thing. The other thing is the utility of additional tests beside the NGS panel. So of course will be like biochemical test, enzyme assay, all these can help in interpreting the NGS results.
So to add to that, I mean, this is definitely a screening test, and it has to be confirmed by some diagnostic test. So by doing such, second tier tests, probably we can confirm the clinical significance of such a finding. So this drawback may not be, may be there in the biochemical based screening also. For example, certain conditions can have, really high levels of some analyte detected through newborn screening, but it may not be clinically manifest, and they may, successfully tolerate such high levels of some of the analytes also without showing any clinical manifestation. So we need to resort to the next level of investigation to confirm whether the finding which we have identified in the screening needs treatment or not.
You mean to confirm in some cases, no? If finally they will develop, or even with complementary biochemical tests. Yeah, okay.
Yes.
Okay, so I think that we can finish. So thank you for joining this webinar, and thank you, Dr. Kumar and Dr. El Khattab, for your talk and for sharing your experience. And so good evening and goodbye.
Thank you.
Thank you.
Thank you very much.
Bye.
Bye.